Oh, the last one for today.
Last one for today. And may I introduce you, Camilla?
Yes, you may.
So I'm so pleased that we're going to have a chance to hear one of our hosts present this afternoon on her emerging work on assessments in music therapy with a particular focus on people with acquired brain injury. If you haven't had a chance to read some of Camilla's work, she has published again outside of music therapy journals in psychomusicology, music, mind, and the brain. Um, she's published one of the measures that she's been working on, the screening of music cognition in adult patients with right hemisphere stroke. And I don't know whether you're focusing specifically on that measure today, that assessment today, Camilla. No, another one. See how busy she is.
No, I
So
will tell you.
we're looking forward to hearing you speak. Thank you very much.
Thank you, Wendy. So it's not my measure, it's a team's work. This is the first thing that I want to say, because although this is new to you, and I'm actually very happy to have this space to talk with you and to you about a Spanish music therapy assessment. We have been seeing and reading and hearing a lot of assessments, and they all have been in English language. So I'm very happy to introduce to you an assessment in a different language. And this is actually an assessment for adults with acquired brain injury. And the one that I'm presenting today is about cognitive functioning and mood. And I will tell you a little bit of how actually we came to developing this assessment. And Wendy mentioned a publication, but this has been an ongoing work for many, many years. So although it's new to you right now, for the people involved, we have been working on it for, I don't know, I think 15 years easily. So let me first tell you what we're going to talk about. First, I will provide you some background information about the assessment and the context in which this assessment was developed, the purpose of the assessment, the structure and how we administer it, the psychometric information that we have till now, and the conclusions and ideas for further developments. First of all, I'd like to acknowledge a group of people who have been involved in working in this assessment actively together with me. First, my colleague Mercedes Cogenex, who is also in this group today, and many other colleagues from Flenny Hospital Institute. This is a hospital in Argentina where we have conducted a couple of studies in regards to music therapy assessments. We also had other music therapists helping out as research assistants for the pilot study that I'm presenting today. These are music therapists working outside of the hospital, and they were trained to administer the scale that I'm presenting today. This pilot study was conducted in the context of my own master's thesis at Berklee College of Music. So I'd like to thank Berklee faculty as well, because they have been supporting me and us so much in preparing the study and also in the publication that is coming up. And of course, the participants, all clients, healthy participants that joined us, and the families who have supported us and have trusted on our work. So first, a little bit of cultural context. This tool was developed in Argentina, and I heard, well, yesterday's Wendy's speech a little bit, and I think several of us recognize ourselves there when she said it's clinically derived. So it emerged from our clinical needs and the clinic that we do with our clients. And this is how we actually started developing the tools or the music therapy assessments that we were working on. But it's not only about the clinical experience. This tool also derives from a cultural context in a country in which it was developed, Argentina. Argentina is a huge country. So for my Dutch colleagues, Netherlands represents 1.5% of the size of Argentina. It is a country with lots of social, economic disparities that affects people's health in many, many ways. First, in their access to education, access to healthcare, their education and knowledge on prevention of illness, accurate assessment procedures, and treatment. Stroke and TBI are the most common types of acquired brain injury in Argentina. Assessments and treatment options are centered in the big cities like Buenos Aires and other cities. So we have people traveling thousands of kilometers to the big cities to get proper assessment and treatment. And then the infrastructure of treatment in other provinces are very weak and fragile. And how the patient evolves in time, that depends often on the huge effort of families and in finding good clinicians, good and well-trained clinicians. The access to accurate assessment and treatment is not granted at all in our country. But let me tell you something about music therapy. And here I want to acknowledge a group of colleagues from the Latin American Music Therapy Committee, as well as my colleague Cecilia de Prince, who's also here today. So Argentina is the first Spanish-speaking country to provide graduate education in music therapy. Since '67, we have music therapy training in Argentina, and there are actually 5 universities offering a bachelor's degree in Argentina. Music therapy is well recognized and developed in some Latin American countries, and it is growing in some others. And in Latin America, 49% of the music therapists are certified. There's a huge effort being made to develop music therapy as evidence-based practice in our countries. In Argentina, music therapists have a professional license, and there is a law for the music therapy profession as well. This means that this law allows music therapists working with people with disabilities to be reimbursed by public and private healthcare providers. That's quite special. So the psychodynamic foundation of music therapy practice, which was typical for Argentina, is actually shifting towards evidence-based practice and neuroscience-informed music therapy. But we are still lacking tools, and we're lacking standardized tools that can contribute to guide clinical practice and interdisciplinary treatment as well. So here you have the countries also where there is some training in universities, bachelor's or master's, and there are some developments occurring in Mexico and Panama as well. So in this whole context of so much disparities in Argentina, I was lucky to get into this huge rehabilitation institute in 2005. My colleague Leticia was also here today. She was the first music therapist at the pediatrics center department, and I was the first one at the adults department. And so it started. Today, there are 5 music therapists working, and there's lots of clinical treatment and research being done. So we're very glad on how things kept growing at the institution and how music therapy also got a place in the interdisciplinary team. So this is a huge neurorehabilitation institute. I think it's one of the biggest of Latin America. So people from everywhere come to this hospital to get treated for rehabilitation. So there we actually encountered, my colleague Mercedes and I, that in the team meetings, all the colleagues from other disciplines would inform about their assessments and how their patients were getting better or not better based on observable evidence and assessments, and we could only inform experience. So we really felt the need to develop some tools that would help us to organize our observations and to communicate to the team what was happening in music therapy. So we did several attempts and developed several things to get where we are standing today. So the first one was an adaptation of the music scale by Peretz several years ago. But that was actually also too difficult and too abstract for patients really to follow and to conduct, and it was not. It was only music perception, and it was not really also including music production tasks or interventions. So it was not ideal. Then my colleague Mercedes, she was working with dementia patients at the hospital as well, and she did an adaptation of the mini mental scale musical adaptation. Then several years later, we thought, okay, let's combine our knowledge, and we developed the screening of music cognition. And that was really a screening. It was a half an hour assessment, and we did a pilot on it, which was published in 2015 on a part of that assessment. And from there, we gained so much knowledge that we thought, okay, let's evolve and let's make it even better. And we decided to split the scale into domains, in one cognitive domain and the language and communication domain. I will be focusing today on the cognitive functions, and that is the ECMO scale that is developed to assess cognitive functions in adults with acquired brain injury. And Mercedes is working on the validation of the language and communication scale. So that this is the work that we have been doing and that I want to talk to you about. So about the ECMOS, that's the evaluación de la cognición musical del adulto con lesión cerebral. That means music therapy assessment for adults with acquired brain injury. For cognitive functions for adults with acquired brain injury. So what is the purpose of our assessment tool? So first of all, as I mentioned before, we wanted to find a way to organize our clinical observations, to understand the cognitive functioning and what was happening also with the mood and engagement. And that's so interesting and difficult about defining the construct, isn't it? What's observable or not of our patient during music listening and music making tasks. We wanted a tool that would let us see information at the intake, at the very beginning of the music therapy treatment, as well in a follow-up stage. We wanted to be able to communicate music therapy clinical practice and communicate to our team about treatment progress, about what was happening in music therapy to guide our treatment planning and goals. We also want to contribute to interdisciplinary assessment and the treatment of adults with acquired brain injury, and contribute to evidence-based clinical practice in Spanish. So, and what's so special about music? We have heard many things during these 2 days, why it's important to include music in assessment procedures. And I think one of the important things that we heard was this morning at the IMCAP presentation, when we're talking about music providing different and meaningful opportunities for clients or patients to display their behaviors in different domains. So this is something that we also see so much in clinical practice when we get that referral. Hey, can you see that patient, please? Because he's not responding in my session. Maybe he does with you. That's something typical of music therapy. So we provide something that's different and meaningful to our clients so that they're able to respond differently as well. Well, as you know, there's a variety of research that shows that music is one of the most demanding and stimulating tasks for cognition. Has the capacity to influence mood, increase arousal, decrease stress, increase motivation, and activate the brain's reward system. If we look into the rehabilitative approach, cognitive functions share a widespread participation of music-specific and non-musical brain areas and networks. There are multiple neurological mechanisms engaged with musical experiences in cortical and subcortical brain structures. So we know if we intentionally direct music towards cognitive skills, music can help to rehabilitate cognitive functions. So for whom is this scale? This scale is designed for adults, and I have put here no limit in age, but adults who have suffered from acquired brain injury, whose primary language is Spanish. This person needs to be able to understand simple commands and have no severe aphasia. We have used the scale with Broca's aphasia, with people with Broca's aphasia, and the scale uses some pictures and picture material, visual material as well. So that works, but there needs to be an understanding of simple commands, and it needs to be a person who is also stable in his or her behavior, meaning that the person is not asleep of course, that he or she have a certain level of arousal, that there is some capacity to pay attention for a period of time, that it can be 10, 15 minutes, and that there is no confusion or aggressive behavior that sometimes display themselves after TBI. And also no hearing impairments. We don't test hearing impairments, but if a colleague says, well, this person doesn't hear well, or there's some problem, or the client himself says, well, that there's something wrong with my hearing, that might not be feasible to use this scale. So, and the scale is composed of a set of materials that we use. First, the assessment form, which is now in paper, and Mercedes and I are working, starting to talk about the digital development of the scale. There is a manual that we have developed as well to administer the scale. And there is additional material, songs with the sheets and with the lyrics, pictures that we use to support the tasks that we use. We need a speaker, and we need musical instruments that we can play either with hands or with sticks, preferably djembes, bongos, congas, or hand drums. The assessment takes place in individual sessions, and on average, we need 2 sessions to use the assessment or to administer it. And we prefer to do that in 1 week's time, because in neurorehabilitation, mainly in the early stage of neurorehabilitation, that can be lots of changes in the first month of treatment. So we try to have an impression of the client at the very beginning. We do administer the scale at intake, and in our clinical work, we have been using it after a month of treatment. And then if you have like longer period of music therapy treatment, you might use that after 3 months again to observe changes. The scale is divided into 4 subscales. The subscale with tasks measuring or targeting attention, different types of attention, memory, executive functioning, and mood. In total, there are 21 tasks, and these are music listening tasks with pre-recorded material. We do sing with the clients, we improvise with them on percussion instruments, and they also have the chance to choose the music of their preference during the assessment. So here's an overview of the skills and the functions that we assess, and a little bit a description of the items. So you see the 4 subskills here on the left, and you see that, for instance, in attention, we will look into focus, divided, sustained, auditory, and spatial attention. Therefore, there are some tasks in which, for instance, the client has to respond to specific sounds, popping into a pre-recorded music, tracking to musical stimuli at the same time, playing music and instruments that are placed in semicircle so that we can see also his or her spatial attention. And we observe the overall level of attention and engagement during the assessment. So these are things and actually domains and functions that we very much look into when we're treating our clients. So this scale is actually organized in such a way that you can keep track of the changes, but also have a clear overview of what you're doing and why, and organize also what's happening actually in the music in regards to attention, memory, and the other cognitive functions. In regards to memory, we look into short-term melodic and rhythmic memory, working memory, musical semantic, and memory recall, and musical memory recall. So there are still some tasks from the first assessment in 2005, like comparing melodic and rhythmic information, or recalling sequences of auditory information that were presented at an earlier stage of the assessment, or a familiar song that we sang at the beginning and then the client needs to retrieve information about that song at a later point. We do offer tasks in this protocol that target concentration, inhibition control, and cognitive flexibility, also making choices during the whole assessment. We look also into variations of the state of mood of the client and the level of interaction. So I'm happy to share this PowerPoint with you so that you have time to look into it later on. This is a bit how it looks like. We have an initial sheet where we have like the more general information about the client. For instance, I think that this might be something that we would not include in European assessments, like the level of education. But in South America, it differs so much. We have people who did never go to school at all and can't write or read. So here we state also the level of school education that people have. This is important also regarding to reading or understanding more complex information. If they have previous musical training or not, and for how long, and was it a professional training or not. This also impacts, of course, on how people perceive music. Here we can just add the scores and have an overall vision of the evolution of the patient throughout time in 3 different moments, and also space to think about therapeutic indications, about if it should be individual treatment or group treatment, what are specific goals for music therapy in regards to cognitive functions on a short term and on a long term. And this is a bit how the first page of the scale looks like. The attention subscale, you have here the scoring and also space for 3 different assessment moments. And in the manual, we explain how it is to be scored and to be interpreted. This is a sample of how the manual looks like. It's now getting around 45 pages, I believe. So we're still working on it. There's a lot to do still. And so, well, we did test it first clinically a lot with my colleague and our clients, and have been changing it. And so we did the first pilot study in 2015 and revised it again. And then the second revision happened actually in focus groups, because Mercedes went more into the communication domain, and I focused on the cognitive domain. So we invited colleagues to help us and discuss the scale and revise the scale with us. So music therapy colleagues, psychologists, neuropsychologists, neurologists, and speech therapists working in this, and music therapists working in this focus group with us. And the second stage was to conduct a psychometric validation of the new scale, so the ECMOS in this case. So let me tell you something about how this pilot validation study went, which took forever. It was the first pilot validation study that I did in a team, and so many things to think about, and it was so complex, and I did learn so much of it. And I think I had the illusion that once that was ready, the scale was ready to go, and it was validated, and it was finished. And now that we finished this pilot study, I think, okay, there's so much to do, and so many things that are missing in this study that still need to be done. So it's still a work in progress. In this pilot validation study, we had 44 participants. We had 24 healthy adults and 20 participants with acquired brain injury, 10 with stroke, and 10 with acquired brain injury, with TBI. So we wanted to see first how actually healthy adults would score on the scale compared to a clinical sample. We had 4 certified music therapists with 1.5 years of experience with acquired brain injury population. They were trained in providing the ECMOS, And actually they came to the hospital and we did role playing and we worked on the manual. And then we did a couple of observations with patients and then we revised it again. So the whole process took around 4 months. It was really detailed. They also completed the Spanish NIH training. And we were in a constant loop of communication with the neurologists, psychologists, and neuropsychologists on site. The procedures for the pilot validation study were that there was a one-time administration. So the healthy participants, our volunteers, these were people that were in the waiting room or family members or some staff members. They were assessed only once. And our clients were assessed also only once, but in the live assessment, we had 2 music therapists assessing, one actually conducting the assessment session and scoring, and the other one was observing and scoring. And these sessions were video recorded and scored again by both the same pair of music therapists at a later point for test, retest, and inter-rater reliability. So looking into the psychometric examination, what we did was looking into concurrent validity, which I found the most difficult and challenging aspect of the psychometric evaluation, and mainly because our patients at the institute where we work, they are assessed with different measures if they have a stroke or a TBI. So we took all measures in for concurrent validity. And the problem was that not all patients could be assessed with the whole set of cognitive assessments. So I'm not quite happy with that, but still we have got positive results. So we used the mini mental assessment. That's a bedside, a very short screening, actually originally developed for dementia. The Addenbroke's cognitive examination is organized in domains like our scale, but was also originally developed for dementia. And the frontal assessment battery is a bedside test to screen frontotemporal dementia as well. And the cognitive linguistic quick test is the only one that was originally developed for people with acquired brain injury. So this one, in regards to the structure and how it was administered, was the most interesting actually for us. And in regards to mood and variations of mood, we couldn't find a proper scale to make a concurrent validity. So we don't have concurrent validity for that subscale. We also looked into the internal consistency of every subscale and the scale as a whole. And that was looking into how well the tool was actually measuring what it's meant to measure. We heard also Dr. McMermott explaining these concepts earlier about intra and inter-rater reliability, or test, retest, and inter-rater reliability. So that helps us to see at different time points the same assessor administering the same scale with the same group, how reliable the level is of correlation, and the inter-rater reliability among 2 different assessors. And we also wanted to compare, of course, how the healthy participants would score in comparison to the clinical sample. So here's a list of the results, and I won't tell them in very much detail. But what I do want to stress here is that, again, the cognitive linguistic quick test, that was the most interesting to us. And actually the results were quite encouraging in regards to concurrent validity. So the music therapy scale had in its attention and memory scale, a moderate correlation and a strong correlation in the executive functioning subscale. If we look into internal consistency, that was an acceptable level of internal consistency. We had an excellent result in regards to test, retest, and inter-rater reliability. And we were very happy about it in the beginning, but that's a big question mark as well. So Why is it so good? Is it because of the previous training that our research assistants received, or is it something else that maybe is not working well in the scale? So this is still to be seen in the next study. When we compared the healthy sample to the clinical samples, we could see, of course, that the healthy group scored much better and much higher than the clinical group, but we couldn't see significant differences among the patient groups, among the stroke and the TBI group, the traumatic brain injury group. So I'll take some time to talk about the conclusions, because this is the most interesting to me. It's still work in progress, as I learned. You kind of never finish these kind of research. And what we could see is that the whole ECMO scale has actually a good internal consistency, suggesting that the 4 subscales combined are comprehensive and reliable for measuring cognitive and affective responsive of persons with acquired brain injury and music. Data for correlating the ECMOs to other measures were limited, since not all patients could be measured with all the cognitive set, as I told you earlier. However, the correlation to the cognitive linguistic quick test was moderate to strong, which was an interesting finding to us. So in regards to test retest and inter-rater reliability, again, we could see that the level of reliability among different raters were excellent for the individual subscales and for the ECMOs as a whole scale. We believe that at some point, the structured nature of the protocol, there are very, very clear steps to follow and how to score and interpret, supported by a detailed and comprehensive user manual of the administration, scoring, interpretation of the responses, seem to have granted the reliability of the scale, but we are not sure. The training period of the raters enabled them to understand the rationale behind scoring and interpretations, and the reliability demonstrate that such training is crucial to proper administration of the assessment. And I'm happy to hear, we heard about the MetaDoc and we heard about the IMCAP, that these assessment tools required us to learn how to administer it, and mainly not only the administration, but how to understand and how to interpret the client's responses from one specific lens. So the MCAP was more about Nora Robbins' music therapy, and this is, for instance, a very clear protocol of music listening and music production tasks. So it's a quite different point of view, and we have to learn first what is the theory behind it, and what kind of music therapy method or philosophy stands behind each protocol. So the volunteer research assistants also stressed the unique contribution of the scale for guiding interdisciplinary assessment and treatment procedures, and delivering evidence-based and culturally sensitive observations. Remember that we have space in the scale for clients to choose the music of their own preferences. So that has been very important as well. The motivational qualities of the scale were identified by the assistants, by clients, their family members, and healthy participants. In short, well, fun seems to be an important thing for an assessment as well. So the clients who were assessed, they were all asking for music therapy afterwards. And although it's not a goal, I thought it was really great to have, or like we heard from the other assessments as well, where you provide these creative opportunities for people to show themselves and display themselves from a different angle, from a creative angle. And for adults, that might be sometimes a bit scary if they don't have any musical experience, but the protocol is organized in such a way that the tasks are like very specific in the beginning, and then they become opener and more creative and more towards improvisation in the end, when the client already has some level of comfort in the interaction with the therapist. And I really like that about the scale. So the scale is reliable to evaluate the patient's cognitive functioning, But we're not at the point yet where we can identify cognitive profiles that would be typical for a specific diagnosis. So what would be typical for stroke? What would be typical for TBI? We can't say that from this small group of participants yet. So it's derived from the clinic, and it has into account also the cultural aspects of Argentinian music. Although the results show overall positive tendencies, this is a small scale study. So we had only 20 patients in this pilot study. And it has also limited psychometric examination. The mixed diagnosis of the clients, the differences in ages and both clinical samples, and the small sample size, and the missing content and construct validity are significant limitations of this study. So next time, we need to include a full and detailed validity examination with a larger number of participants. However, this is the first validation study of a music therapy assessment developed for Spanish-speaking acquired brain injury population. And as such, it does provide a new perspective on how to inform clinical practice in Argentinian culture, and addresses a systematic way of utilizing music in assessment protocols and assessment procedures. A couple of other observations that I'd like to mention, mainly in tasks that included improvising, or for the client to select music of their preference, or to make music of their preference. We have a kind of a structured improvisation in which they choose a background groove or rhythm, and they can choose among different rhythms. These were the tasks, or singing as well. These were the tasks in which participants express openly their emotions, thoughts, and memories related to music and non-musical events. Motivational benefits, along with cognitive problems, frequently occur in individuals with acquired brain injury. So often we work with clients who are apathic, and we could see changes in the level of apathy, the level of arousal, the level of interaction in music. And that provides really another different opportunity for interaction and for displaying cognitive behavior, in contrast to pencil and paper tasks that patients normally have to do with the neuropsychologist. So we do think that it's a great way of contributing additionally to the conventional way of assessing clients in the therapy room by neuropsychologists. And what we also have seen is that often in neuropsychology, when there is a huge motor disorder, or participants have severe visual impairments, they can't complete the scales. And here we could see that patients with visual impairment could do this music assessment because of the, actually auditory and motor nature of it, in the sense of playing music and making music and listening to music. And it was also accessible to people with severe motor disorders. The only task that they couldn't finish or do is the improvisation task. That was, of course, not possible. But all the rest, in which they even could follow a pulse or do a pulse, even with the fingertip, that was possible. So it would be really interesting also to look into technology, how technology can help us to improve music production tasks in assessments as well. Here is a couple of pictures of our team working together. And at last, okay, what's coming next? What's coming next? So first of all, we're very happy because in the next couple of weeks, this study will be published at the American Journal of Music Therapy. So we are very happy about that. And we actually chose the Journal of Music Therapy because we want the music therapy community to be aware of Spanish assessments coming up for acquired brain injury. and we still have time to publish in other non-musical journals as well. Well, with Mercedes, we're finishing the manuals and we're preparing the first pilot training in both scales. So there are trainings coming up in the near future, hopefully. My current PhD study is about multi-centered study in different Argentinian rehabilitation institutes. So we will then look hopefully into a detailed psychometric examination with a larger number of participants and investigate the feasibility and clinical utility of the scale for music therapists working in different institutional contexts around the provinces of Argentina in the country. We hope, of course, to contribute to Spanish evidence-based music therapy practice. And wow, it would be interesting to see in the future the scale translated into some other languages and being examined in other languages as well. So again, it's work in progress. It seems to be never ending, but we're enjoying the trajectory and the process, and we think that it's very significant for our profession in Latin America. So that's all from me.
Thank you so much, Camilla. Big cheer and a big congratulations to you and Mercedes and the whole team on getting this out. And already we've got demands in the chat saying, is it available in English?
I don't know if I do something wrong, but I couldn't see anyone. I was speaking to myself. It feels so strange.
It's the speaker view. It's the little box up on the right-hand side.
Yeah.
Yeah.
Okay.
We're
now
all
I see you.
Where everybody's been shouting congratulations in the chat. But yes, there's a demand. When is it going to be available in English is the first question.
Whenever one of you start translating and validating it in English, we first need to finish the Spanish validation with a larger group.
Yeah. So it's quite a process, isn't it, in terms of you need to validate an assessment. If you're going through that whole standardization, you need to validate it in one language first and then do the whole culturally sensitive translation, which is quite a complex process. So we do have one or two questions. Oh no, the main one was about it existing in English. And I'm trying to figure out if there was no other questions at the moment. So does anybody have a question? Maybe you'd like to turn on your mic and ask.
Yes, do.
We don't have to do chat anymore.
Okay, I'll share the PowerPoint as well. Dr. Tout, she sent me her PowerPoint already, so you're getting a package, a weekend package from us.
Beautiful. So that's going to be in email, not in the chat here. We've got.
Oh yeah. Should we do that in the chat? Is it easier?
I guess not everybody is here actually.
Yeah, that's true. That's true.
A few people have had to leave early. Oh gosh, now we've got people speaking in Welsh to us, which thank you. I'm not even going to try and pronounce that one, Charlotte, but you're very welcome to turn your microphone on and say it.
Charity, can you stop recording, please?
Here we go.